a very good evening to you. I am Lisa Lord, and my special guest is consultant hepatobiliary and pancreatic surgeon, surgical oncologist, and general surgeon here at the Queen Elizabeth Hospital, Dr. Greg Padmore. Dr. Padmore, thank you so much for joining us on your program.
Thank you, Lisa. My pleasure.
Thank you so much. Now, let's start by looking at colorectal cancer. It's a wide area to cover, but we want to concentrate specifically on colon cancer. Before we even touch cancer, let's look at the function of the colon. What is it?
Yeah.
And what does it do?
Yeah, that's a good question. So the colon in general, its purpose is for reabsorption of water. And when you have food, when you digest your contents into the intestine, the small intestine, as it gets into the colon is responsible for the reabsorption of water and pretty much solidifying the stool. And you have a fair bit of colon extending from the right all the way over to the left side and ending into the rectum, which then ends into the anus. So function mainly is for reabsorption of water.
And when you said a fair bit of colon in terms of measurement?
Yeah. In fair bit means at least a good 2 feet or so, 2 to 4 feet of colon for sure.
So we know what the colon is, we know what its function is. What is colon cancer?
Yeah. So if you break it down even more, so cancer in general is where there's uncontrolled proliferation or growth of cells. And as you know, it can happen anywhere. So when we talk about colon cancer, this is where you have uncontrolled or unchecked growth of cells within the colon, and those cells pretty much start to develop into what we call a polyp, which is a protrusion from the lining of the colon. And these polyps then can progress into tumors, and tumors just mean a growth. And these growths can either be benign or malignant. And the malignant growths is what we refer to as your cancers. It's important to know that these polyps, the timeline for development or transition from a polyp to a cancer is generally about 10 years. So it is a slow growth. This is in the patients that are not at risk genetically for colon cancer. But they all generally start from a polyp.
How prevalent is colon cancer in Barbados?
The figures in Barbados, we know that colon cancer is currently the third most commonly diagnosed cancer in Barbados, and that is behind breast and prostate. And globally, it also is in keeping with that, with colon cancer being the third most common cancer globally. So it is in keeping with international data, but the important points to highlight is the stage of presentation of colon cancer, which we touch on as we go along.
Before we get to the stage of presentation and its prevalence, how prevalent is colon cancer in Barbados, let's say, to compare 10 years ago?
Okay. So we did have some recent Barbados National Registry data, and they have shown that there has been an increase in the incidence of colon cancer, right? Compared to before. And it is in keeping with the trends internationally as well.
When you say increase, you need to give me a little more than that.
So as patients who present with colon cancer, the numbers are getting higher, especially more so on the stage of presentation. When we talk about stage, what we're referring to is the tumor confined, or is the cancer confined to the organ of question, so in this case the colon, or has it gone to somewhere else? And that staging classification can be from stage 1 to 4, where stage 4 is where it has spread to other organs. And specifically, when we look at colon cancer in general, those other organs include the liver, the lungs, and stage 1 is where these colon cancer is just confined to the colon.
Yeah.
Yeah.
But I probably was not as clear as I should have been with my question. When I said the increase versus 10 years ago, I meant in terms of stats. So is it a 20% increase from 10 years ago,
Okay.
30% increase?
I have to look at those. I don't know the number right offhand.
Okay, but
Yeah.
the increase is
It's
significant enough
significant.
that it is a cause for
That
concern.
definitely. Yeah, definitely.
Okay, in terms of what you're seeing when you have clinic here at the hospital.
I would say, well, in terms of the outpatient clinics, we meet a wide variety of patients. Anecdotally, we are seeing patients who are presenting later with these colon cancers. And when it's a colon cancer, I also include rectum as
Yeah.
well. So the stage of presentation, or pretty much how aggressive the tumor is at presentation, is we're picking them up later.
Well, let's deal with picking them up to begin with.
Yeah.
What are some of the signs and symptoms that a person should look for when it comes to colon cancer?
Yeah, that's a good question. So in general, I want to highlight that patients can be asymptomatic, right? Which can be a fair bit of patients. Symptoms that you want to address include any blood in the stool, whether it's mixed in or blood coming from per anus, any change in the caliber of the stool. So you normally had a nice bulky stool, but there's no change into a pencil-like, less change in caliber. And weight loss is always one of the things of concern, and any symptoms of anemia. So these include, you may not outright see blood in the stool, but you might notice fatigue, tiredness, shortness, breath on exertion. Those are some symptoms of anemia and can be a sign of colon cancer, or one of the presenting features of a patient with colon cancer, and specifically the ones that are on the right side.
So Barbadians need to be paying more attention to their stool.
Exactly. Yeah.
Do you
Exactly.
find that when you do see patients in clinic, they haven't been paying attention to their stool, they're just wiping, and once it's clear, they go?
Basically. And additionally too, some patients may ignore the symptoms or the signs. So for example, they might have seen some blood or some dark red blood mixed in with the stool on one occasion. It may not happen with each bowel movement, but quite commonly you may see them noticing it for a few weeks, a few months, mainly because it isn't something they notice with each bowel movement. So paying attention or acting on these things early are important in helping to detect or to address these symptoms when they arise.
All right, so let's try to break it down for the public.
Yeah.
You use the bathroom, you see some blood, but you had a very hard stool, you're
Yeah.
constipated, but you tend to suffer with constipation quite a bit. How do I differentiate that from having early symptoms of colon cancer?
Exactly. So constipation on its own isn't a feature. What is more telling is changes in your regular bowel habits, because you do have some patients who are constipated, but one of the things that should raise a red flag is you would have been regularly having a normal bowel movements, but then you find that your norm is changing. And that is what is really one of the things that we like to hone in on. Has it deviated from your normal? So I wouldn't say constipation on its own, because you do have variations in bowel movements. Everyone knows they're normal, but it's the change that is important.
Does everyone know they're normal though?
Well, they should. They
Because
should.
I mean, stress
Yeah.
could trigger changes, a change in diet.
Diet especially. Yeah.
I'm sure that that's a big
Yeah.
issue.
Yeah.
And then you also have hemorrhoids. How big of an issue is hemorrhoids?
I would say hemorrhoids are common. They do cause blood
A lot.
on wiping, or even dripping in the toilet after a hard bowel movement. However, hemorrhoids, we shouldn't just attribute blood in the stools or blood after defecation to hemorrhoids alone. It is important, especially in patients above 40, above 45, that investigations to rule out other causes before we just label the bleeding as hemorrhoids. That is one of the things we like to emphasize. That age is definitely one of the important things in the workup for patients with, or investigations for patients with colon cancer.
Well, let's look at screening and why it's so important. I mean, it's a rhetorical question,
Yeah.
but why is screening so important?
Yeah. Now, screening on what it means is you're looking to detect some disease, or in this case, colon cancer, at a point where you can treat it and potentially cure the problem. Screening for colon cancer is very important because it is preventable, meaning having colon cancer. There are different options for screening, right? And when we talk about a test for screening, we want to look at it from a population level. Is the test affordable? Is the test acceptable to the population? Meaning, would persons go ahead and do this test? And does it change the overall outcomes or trajectory if the disease is detected early? The options for colon cancer, we have stool-based testing, and these tests, they're different. We have fecal occult blood testing, we have immunochemical testing, which looks at DNA in the stools. And what their aims are to detect stool that may not be grossly seen to the naked eye, which then triggers the next step in the screening investigations. So stool testing, if you have a positive stool testing, then we go on to the gold standard investigation, which is colonoscopy. And that colonoscopy is a camera test that looks into the colon and looks at the lining. You do have some virtual colonography. Pretty much what that is a CT scan that is done. You prepare in a similar way for a colonoscopy where you have to pretty much wash out the colon. But instead of having the camera placed, it can be done using a CT scan. Special software is needed for that. However, even though one of the drawbacks to that investigation is that if something is seen, it still have to follow up with a colonoscopy for removal and biopsy.
I know that you didn't mention a barium enema.
Yeah. So in the past, barium enemas were a pretty heavy workhorse in the investigations. However, the false negative rates were pretty high. False negative means that you have a negative test, but you still have the disease.
Yeah.
So because of the high false negative rates, the barium enemas in general are not recommended by international guidelines for screening for colon cancer. They still have their role for different things, but not for screening.
So the gold standard is a colonoscopy.
Yeah, the gold standard is colonoscopy. And then the other non-invasive tests like the stool testing can also be implemented because there are countries and bodies that recommend different options, right? So the stool testing can be done. The intervals tend to be a little shorter, but you always must follow up a positive stool test with further investigation, such as a colonoscopy.
And it is a fairly routine procedure.
Yeah, yeah,
I mean, you do go under anesthesia,
yeah,
but it is routine
yeah.
and relatively safe.
Yeah, it is a recognized, it is many guidelines. So the U.S. Preventative Task Force and the American College of Colon and Rectal Surgeons, many bodies have recommended that as the gold standard test, mainly because you can get a diagnosis of what is happening and you can also do treatment as well. So, for example, the stool testings, those are diagnostic tests where you can get a positive result. But then for therapy or removal of like polyps, biopsies of any masses, the colonoscopy has both of those benefits.
How rare or how frequent is it to go in and find a polyp? Because it could be malignant or benign.
Correct.
But how is it something that usually happens when you go in?
So the chances of finding a polyp, that is a good question because it kind of ties back into when we should start screening, right? Screening in general should recommend, many bodies recommend, as I mentioned, the US Preventative Task Force, the CDC, starting at 45, age 45. This is for the general population. We do have patients who have family histories of colon cancer or colorectal cancer. And a family history in general means that a first degree relative, your parents, a sibling, was diagnosed with this problem less than age 50. And in those patients, screening should be started 10 years before the relative was diagnosed. But that is a special subset of people, right? For the general population, where you age of 45 is the start, it goes up to 75 years old. Anytime after 75 years old is individualized with a discussion with the patient and the doctor about whether we should go ahead and continue screening after 75 or we should not. So that is the general reasoning. So the chances of finding a polyp, it depends on the age of the patient and the population they're looking at.
Are you finding that younger and younger people are presenting themselves?
I would say because I'm at a tertiary care center, my impressions can be a little skewed because
That's fine.
I am seeing the persons that have the diagnosis, right? So anecdotally, yes, I would see more younger persons, for example.
How young?
It varies, Lisa. It can be patients in their 20s, 30s. But again, that is like on the other end of the spectrum. It's not common. Majority is still for sporadic. Sporadic meaning it has happened. Generally present after the age of 40, 45.
My reason for asking that, you said you should look at probably from 40, 45 upwards. I don't have a family history. I don't have any of the signs and symptoms you've noted. But I'm 35 and I want to do a general health screen. Are you going to turn me away?
I would say that it would be a individualized discussion with the patient, mainly because you have to still look at the probability of finding something. So having come for, or I would definitely go through what the chances of finding something are. Is it needed at this time? Discuss the benefits and risk of a procedure. And I wouldn't say it would turn you away, but once we have an informed discussion about the likelihood of finding something, then it usually is approached in that fashion.
And I know you're speaking to me as a surgeon here at the QEH. So as you said, your stats might be a little skewed, but you know why I'm asking this. Because young people, this across the healthcare sector, the private sector,
Yeah.
they present themselves. Maybe they had a close friend that died with it, and they just want peace of mind.
Yes.
So I'm coming to you. What's the drawback of you doing it on a young person?
I would say the drawback, well, it's not really a drawback. It really has to be, if we're looking at it from the cost effectiveness of doing it, we have to look at it on a whole from the population level, right? So in the public system, we have to really entertain who really requires the test. The chances of finding it in this population of patients compared to, for example, a younger population that has no risk of finding a problem, or a lower risk. I shouldn't say none, it's lower. So it pretty much is a resources point, a resources question and where should we focus our resources.
But there's no risk in terms of you going in there per se once everything goes smoothly to the patient.
No. Everything has risk and benefits, but yeah, it's really just weighing, are you using your resources adequately in this population, in this person?
Well, let's look at risk from the perspective that we've noted family history.
Yes.
Who else is at risk
Yeah.
for colon cancer?
Family history is the main thing. Other risk factors, that is really the main one. So when we look at patients with colon cancer, they can either be sporadic. So sporadic means they have randomly had an abnormal mutation and have developed colon cancer, or they could be germline. So germline means you have a family history of colon cancer in first degree relative, and you have a general higher risk of having it. So given these two subsets of people, we have to take an adequate history from the patient and determine which ones they may fall into. And again, this depends too on how they present. Are these someone that is asymptomatic, that is coming for screening, or is this someone that has symptoms, right? The likelihood of you finding something in a patient with symptoms will be higher.
All right, Dr. Padmore, I want to concentrate a little more on the signs and symptoms, but we're going to take a short break. Stay with us. You're watching One on One.
The Barbados Police Service is a dynamic organization which caters to the needs of all residents by providing excellent customer service within our communities. We are excited to inform you that we are recruiting new members to our ranks and welcome your participation.
We are building the Barbados Police Service within our communities. Are you smart, skillful, motivated, ambitious, reliable, and talented?
Smart to fulfill your life's dream.
Smart to chart career opportunities.
Smart to make a difference.
Smart to pursue economic sustainability.
Smart to enable change.
Smart to provide public service.
I say to you today, if you have a love for people, if you enjoy nurturing your communities and taking care of persons, then definitely the Barbados Police Service, of which I am a proud member, is the place for you. So I encourage you, lend us a hand, join us now to help keep Barbados safe.
Come join us, join me in making our country a safer Barbados.
Your place is here in the Barbados Police Service.
Come, join our ranks and chart a career of economic sustainability. Make that difference as an agent of change while providing public service as you fulfill your life's dream.
When does a mental health issue become a problem? When should you reach out for help? I'm Krisnan Hurdle, clinical psychologist and certified life coach. Mental health issues interrupt a person's daily functions. An issue becomes a disorder when a person isn't able to carry out their everyday activities like household duties, personal upkeep and hygiene, or interferes with their ability to function socially, to interact with others inside the household, or interferes with their ability to function on the job or carry out other activities. If a person finds themselves needing to self-isolate, losing touch with reality, or having an impaired ability to think, reason, or function, and if this occurs over a period of days, weeks, or months, then it is time that they reach out for help.
Hi, I'm Dr. Adana Grandison, and I'm here to give you a few tips on how to accurately and safely take your blood pressure readings at home. Before taking your measurement, sit in a calm, warm environment. Don't perform any exercise in the preceding 1 hour. No coffee, food, smoking, or even sinus medication in the preceding hour to taking that blood pressure reading. Empty your bladder and bowel. Most readings that are taken at home should be below or at 135 on 85 millimeters of mercury for uncomplicated hypertension. Lower home blood pressure targets might be advisable in persons who have the following conditions: diabetes, chronic renal disease, or coronary heart disease. If several readings are above 140 on 90 millimeters of mercury, make an appointment with your physician immediately. Ensure to take your readings at the same time every day. We advise 2 readings in the morning and 2 readings in the evening, initially to profile yourself, taken 1 to 2 minutes apart. However, once you have established a baseline, you can choose a time suitable to your schedule where you can monitor your blood pressure readings.
Welcome back. We're chatting with consultant hepatobiliary and pancreatic surgeon, surgical oncologist and general surgeon here at the Queen Elizabeth Hospital, Dr. Greg Padmore, as we examine the topic of colorectal cancer, specifically colon cancer. Dr. Padmore, before the break, we were looking at the signs and symptoms and who's at risk for colon cancer.
Yeah.
But there is something that bothers me, and that is usually with most cancers, and I know that colon is no different, when a person does have symptoms, they are already at a particular stage. Is that correct?
Yeah. Just let me touch on one more thing, Lisa. Back to the risk. If we look at risk on a whole, they can be modifiable and non-modifiable risk factors. So when I mention about family history, that is non-modifiable. The modifiable ones, as you would know, like diet, obesity, physical inactivity, those also can be modified.
The typical risk.
The typical risk, right? In terms of symptoms, and if patients with symptoms are at a further stage, it really depends on where the tumor is, and each tumor behaves differently. The colon is, if I could do some analogies, is like a pipe. And on the left side, that pipe is narrow, and on the right side where it begins is more capacious. So in theory, patients that have tumors on the left side tend to present earlier with obstruction, for example, because that pipe is easier to block, so to speak, and those can present earlier. Patients with right-sided tumors, because the tumor has the space to grow larger, they tend to present a little later. But at the same time, with symptoms, it always really depends on the biology of the tumor. And biology means how aggressive or not this tumor behaves. Because it isn't only size that matters, it's just really how that tumor behaves. So it's a long answer to say that stage is not, or when they present isn't always equated to an advanced stage. More likely, of course, compared to a patient who's asymptomatic, but still it doesn't always equate to being more advanced.
But in your practice, have you seen an asymptomatic patient presenting with late-stage colon cancer?
Not usually.
That's my point.
Exactly.
That's my point.
And with that being said, we are seeing patients more symptoms, which is really, we want to catch the asymptomatic population where cure is higher, where we can remove the polyps earlier, and where we can actually change the trajectory of the overall prognosis.
And by catching it earlier, that means if I come in at 35 and I want to be screened, I really should be seen.
It will be a discussion, but yes, in theory it can be done.
I can work with a discussion. At least we're starting
It has
somewhere.
to be a discussion for sure.
So we were looking at the risk before. You mentioned diet, which is usual with any type of cancer. Is there a particular diet that we should be worried about?
Yeah. Everything, of course, with moderation, but diet high in red meats, pork.
Pork is white meat.
Yeah, but red meats for sure. Yeah. But still, everything with moderation. The problem, or one of the things to take note of with these modifiable risk factors, it usually takes a constellation of factors to increase the risk, right?
And I think why it's so difficult to get people to look at things like diet, you have people that have no family history, they eat exceptionally well, they work out, they don't smoke, they don't drink, and they get colon cancer.
Exactly. And unfortunately, that tends to be patients that it's just a bad luck of the draw. They have been doing everything right. As you said, you're fit, your diet is adequate, but things that we can't control, like the genetics, you know, those things do have a significant role in this cancer.
Well, based on what I just described, and as you said, is the luck of the draw, do you think that doctors face an uphill battle then trying to encourage their patients to pay attention to their diet?
I would say uphill. I just know for sure, especially at a primary care level, with family physicians, the education is a continuous thing. And having that discussion on a regular with our patients, helping for everyone to understand that a healthy diet is crucial, exercising is crucial, and just generally paying attention to your health is important. But it doesn't stop things from happening. It just, we put you at a better stead overall.
What are you seeing here at the Queen Elizabeth Hospital in terms of the presentation of patients? So person comes in, they're symptomatic. 9 times out of 10, are they presenting at a stage 2, stage 3, end stage?
Well, based on that, I will have to quote the National Registry data. And based on that data, the most recent BNR quoted 33% of patients coming in with stage 3 disease, 15% of patients with stage 4 disease. And again, if we look at stage, what that is, stage 4 is when it has gone to other organs. Stage 3 is when it has gone to adjacent lymph nodes, for example. And stage 1 and 2 pretty much depends on the size of the tumor.
But it's restricted to the colon.
Yeah. But as you progress in stage, it becomes more problematic or more affects the survival of the patient overall.
So we've done the colonoscopy. Unfortunately, the patient does have colon cancer. What's the next step?
Yeah. So the next step at that procedure, generally a biopsy will be taken because we need to confirm that it is indeed a colon cancer or rectal cancer. And once the biopsy confirms that, we look to what we call stage the patient. Staging involves imaging in the form of a CT scan. And that CT scan looks at the lungs, it looks at the liver, and it also looks at the tumor itself. Because in our mind, we're looking to plan a possible surgery once the patient is eligible. And it all boils down to, has this patient presented with symptoms or not? What symptoms they're presenting with helps guide us on how quickly a procedure should be done. For example, I would have mentioned left-sided tumors are more likely to cause a bowel obstruction, a large bowel obstruction. So those patients would likely run into issues sooner than patients who are on the right
So
side.
you pick them up earlier.
Yes. Right-sided tumors, I would have alluded to earlier about symptoms of anemia. So symptoms of anemia for these right-sided tumors, because the right colon is capacious, it has room for these tumors to grow. So these right-sided tumors tend to bleed as they outgrow their blood supply. And this bleeding is a slow bleed. So what you may notice is that the stools are looking, we call it a bit darker, dark red blood in the stool, and it tends to be mixed in with the stool. And those patients, in terms of symptoms, they may present more with like fatigue. Patients notice that their regular activities, they're getting tired quicker. And you see that when you do their blood investigations, they're anemic. And there are many different types of anemia.
Of course.
Right? So generally it tends to be a microcytic type of anemia. But in essence, the location helps with determining how the patient would present. If the patient is resectable, the imaging helps us to plan the operation and the timing, which order we should proceed with surgery. So patients in general, we get a final result if we proceed to surgery. We get a final answer about whether the lymph nodes are involved when the pathologist takes a look at the specimen under the microscope.
I want to break it down a little more. I should have asked this before. From the time you do the biopsy to a result, how long does that usually take?
Yep. In general, a biopsy should take 10 days to 2 weeks.
And that test is done here, correct?
Yes, that test is done here. That's done by the pathologist. So that's the doctors that look at these results under the microscope. And they give us an idea of the type, because again, there are different types of colon cancers. So they give us the type of cancer. They give us some cellular features that help us determine the aggressiveness of the tumor. So 10 to 12 days is generally the turnaround time for pathology result.
I want to break down the treatment options bit by bit.
Yeah.
So stage 1, what's our treatment?
In general, stage 1 patients, we, again, no spread anywhere on imaging, because this imaging is a one-time shot, basically. Surgery generally will be the first modality of treatment, and that surgery depends on which side of the tumor is on. Is it only one tumor or not? All right, because sometimes you can have a percentage of patients with more than one tumor. But in general, stage 1, surgery first. Stage 2, similarly, surgery up front. Again, depends on the location. Is the patient fit? So it is a global picture. So we have to look at the fitness of the patient, the history. But in general, if you just look at stage by itself, stage 2, stage 1 surgery, similarly stage 3. When we get into stage 4 is where, as I mentioned, it has gone to another place, whether it's the liver, whether it's the lungs. We have to think hard, are we going to get benefit with doing surgery first, or should we do any other treatment up front? If it is indeed confined to one organ, such as has it gone only to the liver, or has it gone to the liver and the lungs? If it is only to the liver, can we look to do a surgery up front to remove not only the primary, which is the colon cancer, but also can we remove the liver metastases as well at the same time? Or is the location of the tumor in the colon such that it is too risky to do both at the same time? And that generally, the general rule of thumb is if it is on the left side, you have to determine, is it a tumor that is easy to remove from the liver, or is it a major liver resection? So in those scenarios, we may do it in a staged fashion. And stage means we may consider giving chemotherapy first, give the patient time to, because the priority at this stage, when it has gone to somewhere, is controlling the growth. It has already left the colon, and our priority is looking at what is the best option for this patient in getting the best overall outcomes.
So just to be clear, there's no
yes.
chemo in 1, 2, and 3. Chemo is stage 4.
In 3, yes.
In 3, there's chemo.
Yes. And also there's some what we call high risk stage 2. So stage 2 patients, even though they have not gone to the lymph nodes, they are some high risk factors that the pathologist lets us know about when they do their report. So it tends to be more of an individual discussion for some stage 2 patients. The age of the patient, how the cells look under the microscope, that would entertain a discussion about chemotherapy. Stage 3 for sure, yes, once the patient is eligible, because anytime it has gone to the lymph nodes, we don't know has any microscopic cells gone anywhere else. So even though the CT scan looks clear, meaning you don't see anything grossly in the liver, for example, or the lungs, the CT picks up cells that are, or tumors that are at least a centimeter. So as you can imagine, we are catching it at one point in time. So the theory behind, or the evidence behind giving chemotherapy when it is stage 3 is because it has already gone to the lymph nodes and there's a potential for it to have gone distant organs.
And like I said, I'm just trying to get
yes.
as clear a picture as possible.
Yes.
So when you say surgery, stage 1, stage 2, we are removing the tumors alone, or we are taking a portion of the colon as well?
We're taking a portion of the colon. So in general, we have to resect the colon at that portion following their named blood supply. So each part of the colon has named blood vessels running to them, and the lymph nodes follow those blood vessels as well. So when we resect a segment of the colon, we take it along with the blood supply because we need to harvest those lymph nodes as well. We need a minimum number of lymph nodes to adequately say there is no tumor in the lymph nodes. So in recommendations are we take at least 5 centimeters before and after the tumor to adequately have good margins, but you also have to take the lymph nodes which follow the named blood vessels.
Let's look at mortality rates. Now, you quoted some scary stats. More than half of Barbadians are presenting with stage 3 and stage 4.
Stage 3 and 4, yeah.
Colon cancer.
Yep.
Mortality rate.
So, as you could imagine, the higher your stage, the lower your overall 5-year survival. And 5 years is given as a standard in the literature in terms of do these patients in this stage, what percentage survive at 5 years? And what I tell patients is that these figures are pretty much a big cohort of patients, right? But each individual is different. So even though we may say stage 4, maybe 20% survive at 5 years if they're not eligible for surgery, for example. I try not to quote those numbers to patients because each person is different.
Yeah.
And one of the things I want patients to focus on is dealing with what we have right now and getting you through this together. Not looking too much at the numbers because we can quote numbers, right? But we still have to deal with individuals. And one of the things especially with stage 4 disease, if it is indeed only confined to the liver, for example, I generally would tell patients that if you are eligible for removal of that tumor from the liver, that also improves your overall outcomes. But again, everyone is not eligible for that. There's always chemotherapy, but chemo works well to a point. It doesn't completely obliterate these tumors. It causes regression or decrease in size, but it doesn't cure the problem. So in any oncology or any cancer, it generally is a multidisciplinary approach. So we as the surgeons, we are involved in removal of these tumors for patients that are eligible, but we also have the oncologist. So the oncologist gives the chemotherapy, and we have medical oncologists and radiation oncologists who administer radiation. Radiation in colon is not done. It's usually for rectal tumors, but in essence is a multimodality approach. And if we can get the patients who are eligible for each approach one step at a time, that generally overall helps with the outcomes, improving the outcomes.
There is a belief amongst some older Barbadians that they would tell you straight, you're not cutting anything on them. They have this belief that cancer is like a plant. If you cut it, it's going to grow better. What reassurance can you give viewers and listeners to this program that it's actually a good option for treatment?
Yeah, definitely. So it will be a discussion with your surgeon about your fitness for surgery, if the tumor is resectable or not. But that is a whole theory. It's not really true. Removing the tumor doesn't cause it to spread more. I would say that if it was to spread, it would have happened even if we didn't remove it. Because again, we're capturing things, or we're doing these imaging at specific periods of time. So because we cannot control what microscopic cells might have gone other places, this is where the chemotherapy comes in, because chemo works by destroying rapidly dividing cells, which cancer cells generally are. So if you have node positive or tumors in your lymph nodes, we generally push for chemo for patients that are fit for it, mainly because we just want to decrease that chance of you having disease that we're not seeing at this point in time.
Comparison of colon cancer in women versus men.
Comparison-wise, it is still overall we look at third most common cancer. The figures themselves, men tend to have it more. It depends on the site, right? So each population tend to have a little nuance in terms of the distribution, men versus women, but in general, we treat it the same. It isn't really a gender specific thing.
I know, but in terms of what you're seeing in clinic, are more men presenting with colon cancer versus women?
I will be speaking out of...
you don't have those stats.
I don't have those things data right now, but I will look back at the BNR data to see how the distribution is by gender. But for sure, I will have to look back and see.
Okay, I don't want you to speak out of turn.
Yeah.
And in terms of late presentation of colon cancer, how do we stack up globally?
Yeah, so that is a good question. So that 15% stage 4 presentation is definitely higher than global data.
Really?
And what happened is that you will find that the populations that have screening, as in a population level screening, they tend to catch patients early, stage 1, stage 2. So their stage 4 population is much lower. We are kind of on the other end of things, where we have a lower percentage of patients that are being caught in stage 1 and a higher percentage in stage 4, stage 3 and stage 4, which are the stages where we prefer not to catch them. So that is kind of high-income countries where screening is available tend to catch patients earlier. Middle and low-income countries, which may not have population level screening, we generally would be catching patients when they present symptomatically, right?
So we need to increase awareness about screening.
Yeah.
So how do we do that?
I would say more education. We need to understand that there are different options for screening, and a population level screening program has to be thought of and looked at. And again, there are different modalities. So recently there have been more data coming out on DNA-based testing, blood testing. Of course, we have to look at it to see whether it's relevant in our population, because comparing things to North America or other populations, it may not be translatable, right? It cannot be passed from one population to the other. So first looking to see which screening modality is most effective in our population, which screening modality is cost effective, and which one is applicable is very important.
In terms of early screening, now that we're talking about costs, because
Yes.
we do know that colonoscopies are not cheap privately, and everybody cannot get them at the same time in the public healthcare system. I see some colon screening kits being sold online. Should people use those?
Well, I want to focus on a discussion with your family physician, because each test has guidelines. So we just want to make sure that whichever test you use, whether it's one of the stool-based testing, that you understand the step further. If you have a positive test, this is the next step you have to do. Or if it is negative, when next you should have another test done. So it isn't that it should be like a one-off thing. You just have to follow whichever guideline you're using, just make sure you're following the recommendation on the frequency of that test you're using.
Point blank from where you sit as a surgical oncologist, how big of a problem is colon cancer in Barbados?
Colon cancer is a major problem, mainly because it is preventable and we're picking it up later, stage 3, stage 4. So of course, overall outcomes of these patients are lower. So it is indeed a major issue that we need to attack.
If it is such a major issue and it is the third leading cause of death, cancer-related deaths, why is it not getting the attention that breast and prostate cancer are getting?
That's a good question, Lisa. I would say, I guess it doesn't sound, because you're pretty much talking about stool, right? So
no, but that's the thing.
Yeah, it's not
breast affect women mostly,
Yes.
because men do get breast cancer as well. Prostate affects only men, but here's a cancer that is killing. That's not gender specific. So why aren't we talking about it more? And yes, stool is not a pleasant thing to talk about, but we need to talk about it.
Yeah, we do. And I would say it really just is education. I know different societies have been trying to highlight it, Cancer Society, for example, and more work has to be done. I know it will be done going forward. I definitely strongly believe in public education on this topic, along with other cancers, but definitely colon is one of the ones that, given its incidence in Barbados, it has to be also on the forefront.
So in closing then, let's look at some main points that persons should take away when it comes to colon cancer.
So take-home points I want persons to take away: screening save lives. Have a discussion with your family doctor about the different options that are applicable to you for screening. Know that if colon cancer is detected, there is a lot of treatment options, and in general, we'll be looking to take you through each path together, and that it isn't a death sentence, right? So there are options for management, but the main thing is that you want to pick up things before it reaches to that point. But again, we will get you through it together.
And pay attention, of course, to your diet.
Exactly. Do not ignore symptoms. If symptoms arise, don't ignore them.
And pay attention to your stool.
Yep.
It's not a pleasant topic, but it could save your life.
Exactly.
Well, Dr. Padmore, thank you so much for coming on the program and continuing that public education that is so critical when it comes to reducing the incidence of colon cancer on the island.
Thank you, Lisa.
You're most welcome. That was consultant hepatobiliary and pancreatic surgeon, surgical oncologist, and general surgeon here at the Queen Elizabeth Hospital, Dr. Greg Padmore. I'm Lisa Lord. Thank you so much for watching 101. Do have yourself a wonderful evening.